Thank you for joining in. And what I thought I'd do, I think this is scheduled for about 50 minutes or so. So I'm going to split this into half. I deliberately made it a small group so that I'm sure this is going to be more of a dialogue. And I'm sure many of you will have questions. It's always a topic that is filled with questions more than answers. So, and I have Jonathan there who's going to give you his perspective of what it's like living with the condition. Because
can you hear me? This is Teresa Reed.
sorry.
We hear you loud and clear.
So so where was I now? So we're gonna start off. I'm just gonna give you some basics about what it is. Now this condition is actually doesn't only apply to patients with acromegaly. It applies to any patient who develops a problem that affects the pituitary. So it could be a pituitary non-functioning tumor, it could be patients with Cushing's, it could be patients with prolactinoma, it could be patients with having had radiation, for that matter. So it's not specifically for acromegaly patients, okay? So my disclosures. So what exactly is adrenal insufficiency? And often people confuse that and call this condition Addison's disease, and I'll try to demystify that, okay? So in a very strict definition, the definition of adrenal insufficiency is a state where your adrenal glands are not able to produce sufficient amounts of the hormone called cortisol. Cortisol is the hormone that comes out from the adrenal glands, and the inability of the gland to produce the sufficient amounts of cortisol to meet your body's demands. And remember, your body's demands can fluctuate within 24 hours. So it doesn't really mean that your body's demands are constant throughout the day, okay? And so this is what I mean by that. So on the left-hand side, you see here, the brain is up here with the hypothalamus and the pituitary, and it's closely regulated by what we call the diurnal rhythm, meaning, your sleep-wake cycle. This is why I typically explain to patients is a bit like, when you feel when you are, say, in another time zone or you're in jet lag, and that's how you feel because your body clock has not actually reverted back to the normal or the local time. So it's the diurnal rhythm and the sleep-wake cycle that actually governs or sort of controls the hypothalamus, which subsequently produces CRH, corticotropin releasing hormone, which then regulates the production of ACTH coming out from the anterior pituitary, and that subsequently regulates the adrenals to produce cortisol. And you can see here, this is all working nice and dandy. And obviously you have on the left-hand side here other things that can affect your life, stresses, low blood sugars, low blood pressure, things like that, trauma, pain, infections, surgery, all the things that we all experience, and that can actually affect this very delicate cycle, a very delicate balance very closely. And as you know, cortisol is a very important hormone because like growth hormone, you have cortisol receptors in all over your body. And not only it regulates many of your body's functions, it also regulates your blood sugars. It also regulates your heart, regulates your sodium, it regulates your bones as well. So there are many things that cortisol does, okay? And this is what I mean by the diurnal rhythm. So in a person who generally goes to bed at, say, 11 or 12 and wakes up at 6 or 7, you can see this is what normally should happen. Cortisol production tends to be highest in the mornings and tends to be lowest at night just before you go to bed. And the whole point of the reason is because cortisol being highest, your body's kind of primed, so that you start your day with your cortisol being high. It gives you energy. You are woken up from your sleep. You're refreshed. You start your day, and you're full of energy. And towards the end of the day, when you're supposed to be tired and you're mentally fatigued, and this is when your cortisol is actually lowest to enable you to go to bed. That's the normal physiology, okay? And like I mentioned to you earlier, it's a matter of some demand and supply. This is actually quite a very nice study that was done a couple of years ago, where they looked at people who were training 6 weeks, physical training, rowing. And you can see here on the left-hand side that when stress occurs, you see that your cortisol demand rises as soon as your body gets stressed. And I'm talking about physical stress, okay? Like physical activity, big time, hardcore activity. Now, your cortisol, and this is normal people, by the way. So your normal physiology is that cortisol production actually decreases temporarily, and that gives you a cue, or gives the brain a cue to produce cortisol in response. So you need the stress, you need the slight deficiency to allow the brain or the cortisol production to be increased, as you can see in this part of the graph here, to meet the demand that is required to counteract the stress. Okay, and that's why you want it to be more efficient. So this is a very tightly knit mechanism, or a very tightly knit mechanism to control your cortisol production. And these athletes, when they did physical training for 6 weeks, this is hardcore. Your body gets entrained to the stress. So whenever you get this stress, your body's ability to produce cortisol is more efficient after you're having this physical training. And what happens is that in a person who is not able, or who has adrenal insufficiency, meaning by definition cortisol deficiency, is not able to meet that demand, you will see that the cortisol secretion does not go up as it should. And therefore, you feel that you're running. It's almost like a car going uphill. Your car is low on gas. You're kind of choking. Your car is not kind of going at the speed that that is supposed to be. And that's what it means by supply and demand. And so, in a normal person, you see on the left-hand side here, you have the hypothalamus producing CRH, stimulating the anterior pituitary to stimulate ACTH, and then adrenal cortex, you have cortisol being produced. And the cortisol that is being produced then goes back to negatively inhibit and the pituitary and the hypothalamus. And this whole mechanism here is designed, and what I like to call it is like a thermostat. It controls the temperature in your room. If it's too hot, the thermostat switches on, controls and regulates the brain so that the cortisol production is maintained at a steady level. And so in a person with adrenal insufficiency, it's the adrenal glands that are not working. That's what we call by primary adrenal insufficiency. So anything that affects the adrenal glands that makes them not work results in primary adrenal insufficiency. And what are the causes of primary adrenal insufficiency? The most common causes is autoimmune, meaning autoimmune diseases. So any disease where your body produces antibodies that attacks your own organs. In this situation, it attacks your adrenal glands. It causes the reduction in the ability of the adrenal glands to function. This is the condition that is often referred to as Addison's. Infectious causes, meaning you can have infections that affect the adrenal glands, bleeding into the adrenal glands, metastatic disease, cancers that spread to your adrenal glands, medications that can stop the adrenal glands from working, and obviously surgery. You remove your adrenal glands, you can develop adrenal insufficiency. These conditions are not you don't refer them as Addison's. So the Addison's is basically the autoimmune cause of primary adrenal insufficiency. That's a big mouth. So in short, they call it Addison's disease. Okay. Whereas secondary adrenal insufficiency, which is what most patients with acromegaly has, is where the problem lies in the pituitary. So the adrenal gland is working perfectly fine, but it's just not receiving the signals from the pituitary. And the analogy I use is a bit like your laptop. You know, if the laptop is like your adrenal gland and it's not receiving signals from the Wi-Fi, so it's not going to work, right? It's not going to download what you're trying to download. And so the problem typically with the secondary adrenal insufficiency is that the degree of adrenal insufficiency in secondary adrenal insufficiency is not as severe as primary adrenal insufficiency. Why? Because the adrenal glands are still working. It's just that it's not receiving the signals. Especially when you're hit by a stressful situation where you need more, the body needs more, the demand increases, you're not able to meet that demand. And that's why the adrenal glands continue to work, but it's just not working to the level that you need it to work, in, especially more pronounced during stressful situations. That makes sense. Okay. And what other causes? Well, you can see here the causes again is listed here. Obviously, pituitary diseases is one of them, and pituitary diseases necessitating surgery, like many acromegaly patients have. That's another reason for secondary adrenal insufficiency. There's also inflammatory causes. There's also autoimmune causes, again, similar to the Addison's disease, where you have autoimmune disease attacking the adrenal glands. You can also have an autoimmune disease attacking the pituitary gland. It's called hypophysitis. It's not called Addison's. Okay, you can have bleeding into the pituitary, like pituitary apoplexy. You can be born with a abnormal or not developed pituitary gland that's not developed. You can have genetic causes. You can have head injuries that affects the pituitary gland. You can have breast cancers that metastasize to the pituitary gland, and you can have medication. So the list is actually longer, but the degree of severity of secondary adrenal insufficiency is not as severe generally compared to primary adrenal insufficiency. So the symptoms are often non-specific and insidious. Fatigue is usually the most commonly reported symptom. And then you can see the list, you can read there on yourself. Everything else is actually can occur. It can range from being very mild to very severe. Sometimes it can be associated with nausea, vomiting, and weight loss. And don't forget, because it also affects the pituitary gland and other pituitary hormones, secondary adrenal insufficiency patients can also report of loss of libido, loss of axillary and pubic hair, and other symptoms as well. Now, the major difference is that unlike primary adrenal insufficiency, where when the adrenals are not working, your ACTH levels will go very high. In secondary adrenal insufficiency, your ACTH levels are actually much lower than primary adrenal insufficiency. And that is the reason why you don't get skin darkening in secondary adrenal insufficiency compared to primary. And also don't forget that we know that the adrenal glands produces a hormone called aldosterone. Aldosterone is a hormone that maintains salt in your blood. So it maintains your blood pressure, because if you lose a lot of salt, like what you do when you're having diarrhea, vomiting, your salt goes out, your fluid goes out, your blood pressure tanks. In this situation, there is a hormone that is actually produced by the adrenal glands called aldosterone, which is a mineralocorticoid. Unlike the cortisol, which is a glucocorticoid, this is a mineralocorticoid. The mineralocorticoid activity is intact because the adrenals are still working. So low blood pressure and high potassium, which is often the case with primary adrenal insufficiency, is less common in secondary adrenal insufficiency. Okay, so how do you diagnose and how do you test? It's a challenging condition to recognize because, like I said to you earlier, the symptoms are often non-specific, and they're not very. Sometimes it can be quite subtle as well. Testing should not be performed when patients are already on steroids because it can affect the interpretation of the testing. And so the types of tests you would use is either you can do a morning 8 to 9 a.m. Blood cortisol, and if it's less than 3, this is very highly suggestive of secondary adrenal insufficiency. If it's above 15, it's very unlikely you have secondary adrenal insufficiency. So values in between this range, meaning anything between 4 and 15 or 4 and 14, requires further testing. So here is a study where they looked at patients with 3 different conditions that causes adrenal insufficiency. You have primary on the left, secondary in the middle, and patients who are treated with high doses of steroids, what we call exogenous glucocorticoids. And you can see the difference in ACTH levels. Again, I had alluded to you earlier, the primary adrenal insufficiency, you tend to see ACTH levels that are high, as you can see here, whereas the secondary adrenal insufficiency tends to be much lower, which can overlap with those patients who are taking high doses of steroids. Okay, so those patients who have morning cortisol that ranges between 4 and 14, where there's additional testing is needed, this is often the time when we will consider or recommending performing what we call a CST, the co-syntropin stimulation test. And what we do in this test is you come in, you have a line put in our infusion unit. That's where we do it here in this building. Actually, the nurse will put in an infusion line, will draw blood to measure your baseline cortisol, will give you a medication called co-syntropin, which is basically the drug version of ACTH to stimulate your adrenals, and then measures your cortisol at 30 and 60 minutes. And then we will see how high your cortisol levels respond following that stimulation. And the higher it is, anything above 15 will qualify as not as having a normal adrenal function. Okay. So this is a study where they looked at using insulin tolerance tests, which is another way of performing the test to assess for adrenal insufficiency. And you can see here, those of you who have had an insulin tolerance test will know how uncomfortable it is, because what you do is that you have an IV line where insulin is administered, and the whole point of the exercise is to tank your glucose levels. As you can see here, you drop your glucose levels, and the low blood sugars or low glucose levels will stimulate cortisol production and ACTH production. And you can see here, in this case, the normal production in a normal person is the ones in black. You can see the rise in ACTH after 20 or 30, between 20 to 40 minutes, with the concurrent rise in cortisol levels, as you can see here. Whereas in a patient who has adrenal insufficiency, secondary adrenal insufficiency, you see that the ACTH remains blunted, and in fact, it's just flat, and the cortisol levels rises only very subnormally, but doesn't go up to the levels that as you would expect, like the normal person does. And it's almost like, the analogy I use is almost like you're putting the adrenals on a test drive, like a car. You're test driving the car to see whether it fulfills the criteria or not. Okay. So these are the medications that is often used. We call them steroids, which is the lay term. The medical term is called glucocorticoids. As you can see here, there are different types. Obviously, hydrocortisone is the preferred option, but you have hydrocortisone, prednisolone, and dexamethasone. We generally do not like to use the dexamethasone because it's the most potent of all the 3 steroids, but in rare occasions, it can be used, but it's generally not the most common steroid that is used. The most common one is hydrocortisone, and there are different ways of giving it. You can see here, depending on the level of severity of adrenal insufficiency. So obviously, if you're mildly adrenally insufficient, you just probably only need 10 milligrams upon waking. If you're a little bit more severe, you can do 10 in the morning and 5 milligrams around 5 to 6 hours later, roughly usually around noontime. And if it's even more severe, you can do 15 and 5, or 15 and 10, or 20 and 10. So these are the typical regimens or typical doses. And again, it's variable from person to person. In a person who has primary adrenal insufficiency, they will also need fludrocortisone. But in a person who has secondary adrenal insufficiency, you actually do not need fludrocortisone. Okay. And like I said to you, it's only for primary adrenal insufficiency. So Bella raised the hand. I have to move on, and I'll come back to her question later. So DHEA can sometimes is not infrequently it's infrequently used. It's shown in some studies that there's subtle improvements in terms of energy, but it's generally not recommended except in some select patients, particularly for those with low energy and those with low libido. But it's really not the common practice to replace DHEA. Often it's just hydrocortisone that is used. Okay, so compliance is critical. Make sure you take your steroids as needed, as directed, sorry. Know when to stress dose. This is highly important. I have Connie there, who's my nurse, who helps me a lot with answering the questions and educating patients on how to deal with stress dosing, typically during the time when you're having an infection or an illness, and what are the symptoms of it, and to acknowledge and to recognize the types of symptoms associated with adrenal insufficiency, which I'm sure Jonathan will elaborate the symptoms that he has experienced. Always carry extra steroids with you, know when to call for advice, and these are the general fundamental principles of managing adrenal insufficiency: good hydration, regulation of blood sugar, blood pressure, and then obviously, managing pain.
Sorry.
Factors that require stress dosing. This is the list here, meaning what actually causes or what actually necessitates stress dosing. Often infections during the time when COVID came, there was a lot of confusion because we didn't know what COVID did. Obviously, there was a time where we recommended using high doses, tripling the doses of steroids to stress dose during the time when a person had COVID, especially when they continue to have fever, unrelenting fever. Surgery is another thing, so make sure that if you're having planned surgery, you need to inform your surgeon or the anesthesiologist that you're on some steroids and they need to give you extra doses to accommodate surgery. Acute illness like infections, like pneumonia, for example, is a big one. Severe stress, I'm talking big stressful events, not the minor ones. Big stressful events like bereavement, for example, is the one. Physical trauma, strenuous exercise, especially if you're going on a heavy hiking activity, that is something that you may want to consider. Dental procedures, labor and delivery. For those patients who are also on high doses of steroids for a variety of reasons, like for example, for their asthma or for their arthritis, and if they abruptly stop their steroids, if they do get into problems with maybe they have an infection, they may need to also stress dose. That's simply because when you've taken high doses of steroids for a long period of time, your adrenals shuts down, and when you are dealt with a stressful situation, you will need to stress dose. And also when you're switching between different types and doses of steroids, because there's a gap there where your body isn't able to compensate for that need, and that's also another requirement for stress dosing. So for any surgical or dental procedures, it's always a good idea to contact and inform your provider who's performing the surgery that you have this condition, so that they're prepared to administer. Often, usually, if you're nil by mouth, you're not able to take anything because of anesthetic reasons. They usually would give the steroids to you in the form of an IV or an IM, intramuscular steroids. And once that is done, and once you're able to eat and drink again, sometimes you can revert back to your normal steroid dose quite quickly the next day. And sometimes if say, for example, the pain is prolonged from a surgery, the provider might want to keep you on a higher dose of steroids for a little bit longer and then gradually taper that down. Again, there's no fixed rule about how do you taper. Generally, I would say you could just drop the dose by 5 milligrams, starting with the evening dose and then followed by the morning dose. And you gradually drop it over a period of 5 to 7 days. But it really depends on every individual. It's really different from person to person. But again, if you're unsure about the tapering schedule after you've had the procedure or after you've been discharged from hospital, then obviously make sure you call the clinic and get additional information. And in my clinic, I'm always grateful I have Connie to field those calls for me. Okay, so she's the go-to person for me. Okay, how do you stress dose? Again, simple. Again, this is I deliberately didn't want to make it too complicated because you won't remember this if it's too complicated. So if you, for example, have a fever, but you're still able to keep your food intake down, it's simple. You just double the dose. If you're doing 15 and 5, you just do 30 and 10 milligrams. And sometimes if the fever is unrelenting, it's continuous after 3 or 4 days, you may even do triple the dose, 45 and 15 milligrams, so you might want to do that. And also don't forget, especially during the time when we had COVID, it was really difficult because patients didn't know what to do. And so it's always a good idea if you're unsure at this point after you double or triple the dose and you're still not getting any better, then obviously call your primary care physician. So adrenal crisis. A lot of patients talk about adrenal crisis, but I want to make sure I highlighted this to you. There is a specific definition for adrenal crisis, which requires a set of criteria that you need to fulfill. Feeling a little tired, a little lightheaded is not adrenal crisis, okay? Yes, adrenal crisis can be life-threatening because it basically means that your body, the blood pressure drops very severely and the perfusion to your major organs like your kidneys and your heart and your brain is compromised. And that's why it's life-threatening. But at least two of the following needs to be fulfilled to be deemed as having adrenal crisis. That is very low blood pressure. We call them in medical terms hypovolemic shock, nausea and vomiting, and this is the severe ones where you're not able to keep anything down. Sometimes you can add in diarrhea as well, where you're losing fluid very quickly and you're getting very dehydrated very quickly. Profound fatigue. Now, we are talking about the fatigue that is really out of this world, not the tiredness that you're not able to get out of bed. This is really profound. Fever and sometimes also impaired consciousness. So this is really the medical definition of adrenal crisis. And then when you are doing, when you're taking this labs, typically what you would find is that the blood sugars are low, blood sodium could be low, elevation of white cell count, which could be related to the underlying infection. And because of the reduction in volume, your kidneys are compromised, so you have an impaired kidney function, and kidney function can be impaired. That's also not great either. So adrenal crisis management simply is that, obviously some patients may have forgotten or elected not, or for whatever reason did not take their dose of their steroids, and their symptoms are worsening. So typically, if it's worsening, you stress dose, and if the symptoms get better, great. If the symptoms do not get better over a period of 24, 48 hours and you're continuing to vomit and you're continuing to lose fluids, that's when you will need to go to the ER and get IV fluids administered. So this is really just to give you some ideas on what to do, obviously not to know when to seek help. And hydrocortisone is usually the medication given in the form of IV, because especially if you're not able to keep the oral tablets down, you take the IV hydrocortisone. It can be given in two ways, either 100 milligrams IV followed by 200 milligrams a day of IV infusion. So the first dose is a bolus, meaning they give it to you at one go, followed by an infusion, or sometimes they can give it to you like 50 milligrams IM every 6 hours, which is still basically roughly about 200 milligrams a day. And that should also concurrently occur when you need to be rehydrated, because like I said, the key theme of adrenal crisis is fluid loss. So you need to replenish those fluids, sometime in the form of normal salines, up to 3 to 4 liters at times. And the vitals is going to be helpful in giving you an idea of how much fluid rehydration that needs to take place. And especially for those patients who have low blood sugars as well, a bag of not saline but dextrose, which is basically glucose, could be given as well to treat the low blood sugars. And then at the same time, find and treat the underlying cause of the adrenal crisis. For example, is it due to a pneumonia? Then we need to treat the pneumonia. If it's due to a surgery, then obviously there's not a lot you can do about it. But the cause needs to be identified. There usually is a cause of why patients go to develop adrenal crisis. And so these are the things: the ID card, the wallet card, the medic alert bracelet, carry extra tablets with you, emergency packs also. Again, for those of you who are traveling overseas, make sure you carry some steroids, oral steroids, and also maybe even an injectable steroids as well, just in case, especially when you're in a place where you're not able to get to a hospital and get IV infusion of the hydrocortisone. In some patients with secondary adrenal insufficiency, the HPA axis or the adrenal axis can actually recover, but it does take time. It doesn't happen overnight, especially for those who have mild adrenal insufficiency after surgery. Very occasionally, up to 15% it can recover, but again, like I said, it's a small proportion of patients. So for those of you who have had surgery, so these are what we teach our medical students, is that these are the predictors of recovery of this axis. So for example, if the patient has a small tumor and diagnosis normal IGF-1, normal testosterone, or normal menstrual cycles, we call them gonadal function, there's a good chance of recovery. Tapering and stopping opioids may help, because opioids also is another cause of adrenal insufficiency. It's a form of, as you know, it inhibits the production of cortisol from the adrenal glands directly. Use the lowest possible dose of steroids, and check morning cortisol every 3 to 6 months in anticipation of the recovery. In some patients, sick day dosing may still be needed after a year after recovery, because your adrenal glands and your brain still is not up to speed in terms of responding and reacting to stressful situations. So I think with that, I end my talk, and I'll hand over to Jonathan. Maybe he can explain to you his journey and how he deals with it from a personal level.
Sure. Thank you, Dr. Yuen. That was amazing. So, first thing I wanted to do is just a little bit of show and tell. So I brought a little pack here that I use to store my hydrocortisone, which I'm going to pass around. I just wanted to point out a couple of things. I have this emergency card in the pack. It has a QR code that links to my physicians, my medications, my conditions, and so forth. It comes from, I'm going to just plug them, an app called Guava. And what that does is it will bring in all your information from all different portals into one place. So let's say you've had blood tests at a whole bunch of different places, and you want to just see your IGF-1. You don't have to like hunt and peck each different portal and grab it and put it together and chart it out. This will all do it for you, and it's free. Guava, like the fruit. I'm going to pass it around. You're gonna see this. I have a tile because I lose this. I have a little pill case here where I used to store the extra hydrocortisone that Dr. Yuen mentioned. So that way, if I'm out somewhere and forgot my hydrocortisone or something, I have that in here. We've got the injectable Solu-Cortef. One place I recommend to get it, because Insurance never seems to cover it and it's always expensive, but the Amazon pharmacy has worked out really well for me. The other place to look is GoodRx, and that'll link you to whatever has the best price.
Make sure you also ensure that the expiration dates.
Yes, so I put a reminder every year to replace it. And I also have two in case I mess up the first one. So I have one actually in my house and one I have here with me. I have instructions here, so EMTs and whatever, can take a look and see what to do. I have some Band-Aids because those are always good, some alcohol wipes, some hand sanitizer, and I think 2 syringes, again, just in case. So here, I'm gonna pass this around so you can all take a look and have some fun. The other thing I wanted to point out is my medic alert bracelet. And so I have, I get this from Road ID, so I highly recommend it. I don't own any stock in them or anything, but this is basically indestructible. It's laser engraved, it doesn't wipe out, it's really, really good. I have my name, year of birth, so everyone can figure out how old I am. That seems to change every year. I wrote, again, for me, do not resuscitate, DNI, that's my own personal choice. I have my emergency contact, and then this is the most important part, adrenal insufficiency, need cortisol. And then the last thing is I have this little URL. So Road ID has something that you can use, but you have to pay for it. I'm against paying for things that you can get for free. And this is a little URL. It links to something. People put it in. They can get my medication list, physicians, all sorts of. I have the actual the instructions there on how to inject it. It's all there at this URL. So I'm just going to pass this around so you can take a look, see it, touch it, whatever. So I'll talk about a little bit about the secondary adrenal insufficiency. So I was diagnosed the morning after my second surgery. Beforehand, the endocrinologist said to me something like my cortisol was at, or the morning after surgery, I think it was at 4. And you're looking for it to be much higher because, right, you're in distress, but it was at 4. So she goes, you got it. And so I went from the hospital to the clinic. And by the time I got to the clinic, I was nauseous, I was dizzy, I was all sort of disoriented, and I was vomiting everywhere. And they gave me the intravascular stuff right then and there, and that got me better. I'm very good at taking all my medications. I have an app. I know at this time I take this much of this, and that time I take this much of that. And I have that all figured out. We're going to fast forward 3 years later. I wake up in the morning. I'm not feeling really good. So I call my doctor. I'm not feeling good. He prescribes me this, and I have some headaches, and she prescribes me that. And this goes on for 2 or 3 days, and I'm getting worse. I don't know what's going on. And somewhere in the back of my head, I knew about I had secondary adrenal insufficiency. I mean, I wore my bracelet, but there was no mechanism for me that says, there's no alert that I got that says, you should be stress dosing now. So I got worse. I was vomiting everywhere. I didn't stress dose, and I ended up in the hospital for 3 or 4 days. So what I actually did is I have a sign on my closet, and it says, stress dose. And so every time I walk past it every morning, I consciously think, do I need to stress dose? Yes or no? And so on and so forth. Fast forward to last October, I had my 3rd pituitary surgery. Surgery was on Monday. So they gave me the pre-op medication. Everything was fine. I was in the hospital Tuesday, Wednesday. Everything's great. I go back, I get out of the hospital Thursday, and they told me to go back to my normal dose. I went to my normal dose. Thursday afternoon, I went for a walk, and then I went to sleep, and I woke up on Monday evening. Basically, I slept like 4 days straight. And I remember my dad was staying with me. He was like, maybe something's not right. I'm like, no, this is normal after surgery. But Monday night, I couldn't move. I had no appetite. And so I called the clinic. And maybe you have an adrenal, maybe you're having you need to stress dose. They're like, nah. They're like, try it. And by the next afternoon, I was feeling 100 times better. And so what happened was clearly, as Dr. Yuen said, that we had tapered back to the original dose way too quickly. And so it was triple the dose for a couple days, then a couple days later, double the dose, then we were back to normal. I just wanted to throw in one little personal experience that was a little different than what Dr. Yuen mentioned. was I actually have low blood pressure. And so in August, I got up in the middle of the night and I'm on medication for it and everything, but I wasn't on enough and I fainted, fractured my nose, was bleeding everywhere. And thank God it was only that. It could have been much more serious. So I was actually on fludrocortisone, even though I have secondary adrenal insufficiency. That's used for low blood pressure. I just wanted to point that out. And my dose, of course, is different than what Dr. Yuen mentioned. I take 12 and a half in the morning and 5 in the afternoon. So go figure. But what's nice about that is my doctor prescribes it as if I'm on 20, so I do accumulate some
You
extra.
have a stash.
I don't know if it's a stash, it's the emergency fund, right? So I have the emergency, then again, I don't have to sit here and, really penny pinch when it comes to stress dosing or not. I'll let you make the decision. If you're not sure if you should stress dose or not, what's your opinion?
And ultimately, you know your body the best. Nobody knows it. And if you've, especially like in your case where you've had several experiences, I think, it makes you wiser, right? Hopefully. So if you know that, yes, I would say have a threshold, because ultimately the whole point is to avoid you getting to that situation where you need to be hospitalized. You are trying to avoid hospitalization and avoid being in ICU.
Right, so I think to Dr. Yuen's point is he put up the symptoms of an adrenal insufficiency or adrenal crisis. We don't want to wait that long to stress dose. We want to do it a little bit beforehand, at least. So yeah, I think what he was basically saying is if you're not sure and you have the extra hydrocortisone available, by all means, do it, and then you can, sort of figure it out later. But I think stress dosing for an extra day is not going to do, any significant harm. And I know he's the star, so I'm done. And feel free to ask him whatever questions.
So I'll come back to your question in a second. There's a question about from the virtual group. I read somewhere that stimulants like ADHD medications can cause adrenal insufficiency. Is this true? Not that I know of. It's not typically in the list of medications that you would think of that causes adrenal insufficiency. It's usually medications that reduces cortisol production, typically like the medications we use for Cushing's disease, like ketoconazole, an antifungal medication. That can sometimes do it, especially in high doses. But I'm not aware of ADHD meds.
Yes, when I saw your presentation here, I realized several things that maybe my medical professionals have me doing wrong. Now, one thing I want to ask you, is it possible for someone to have primary adrenal insufficiency, which is not diagnosed, and then having pituitary surgery, and then 15 years later, they realize that you're adrenal insufficient and diagnosed me as secondary. And when they put me on hydrocortisone, I'm suddenly able to stand up and walk after being in a wheelchair for 15 years. They did a stim test. The stim test did not increase my cortisol, which to me would sound like primary, but they told me because I had pituitary surgery, that the diagnosis goes to secondary.
Yeah, I see why you're trying to ask that question. So let me answer your question in two parts. Okay, the first part is if I heard you correctly, you said that you had the primary first before you developed secondary.
Well, I suspect that, but they never tested
Yeah,
it.
so if you have primary adrenal insufficiency, like I said to you earlier, the severity of adrenal insufficiency tends to be greater, much greater.
Yes.
And often much more symptomatic than secondary. Secondary tends to be generally I say milder. And again, I showed you the slides earlier. Primary adrenal insufficiency means that your adrenals itself, the gland itself, is actually not working. And so often you would be more at risk of developing adrenal crisis if you have primary versus if you have secondary, because of the severity of it. So if you have primary adrenal insufficiency that goes on undiagnosed, you're darn lucky that you could have got away with all those years without steroids.
I
You can't be
think
better count your lucky
it's a
stars.
miracle I survived.
Now, it's that's not to say that in a person who has underlying primary AI, then has a pituitary tumor, has pituitary surgery, and then develops secondary, AI. But basically, at that point in time, it doesn't really matter. You have AI, period. The treatment is the same. Who cares whether you're primary or secondary? You know, the fundamentals of treating AI is the same, still needing steroid replacement therapy.
Now, next question, I carry injections just like this gentleman does, except my doctor has me carrying dexamethasone.
Yeah.
And your slide says I
Yeah.
shouldn't be taking.
No, my slide says dexamethasone is not often recommended because dexamethasone has more side effects than if taken long term, especially in higher doses. That's not to say that you cannot take dexamethasone. In some very rare select cases, you can still use dexamethasone, but it's just that you have to deal with the side effects of steroids because dexamethasone is a lot more potent than hydrocortisone. And in terms of the injections, you can either use Soliportab, which I think that's what you have. It's basically a hydrocortisone preparation. And if the pharmacy doesn't have it, you can sometimes use dexamethasone injections as well.
Is that why they put me on dexamethasone? Because
Maybe because sometimes if the pharmacy doesn't have, but if you're using dexamethasone using it over a short period, that's okay. Yeah, the key thing is not to take it over long periods if you're using dex.
now, adrenal crisis. I looked up the wallet cards you take. Some of them say low blood pressure, some of them say low or high blood pressure. Now, I have both, and it depends. Some days my blood pressure is 250/125. Some days it's 80/40.
So if your blood pressure is that high, then what's what I'm trying to use? It's the lesser of the two evils. Having that high of a blood pressure is the lesser of the two evils than having such low blood pressure because
But try to tell my primary.
what happens is in terms of adrenal insufficiency, because it tells me that your organs are well perfused because your blood pressure is to that level. You know, because most people when they die of adrenal crisis, it's because of whole organ failure due to impaired perfusion of those organs. You know, so from the adrenal if you understand me correctly, from the adrenal insufficiency standpoint, having a good blood pressure is better than having a low blood pressure.
So having-
Now, if you talk about blood pressure being that high, that can give you strokes, that's a different argument. You see what I'm saying? But adrenal crisis, often the causes of death is because of the organ failure and
No, it's
and,
organ
lack
failure
of organ
from
perfusion.
low blood pressure.
low blood.
Okay, that's what I thought, but my primary doesn't understand that.
It's very fine detail there.
Okay,
The principles of
now, next question.
maybe I need to let other people ask a question if I may.
Okay.
Is there anyone else?
Hopefully very quick one. You mentioned that when you perform a cositropin stim test, that you do so, you take the blood with an IV line. Does that mean that you can avoid being pricked each individual?
Oh, yeah.
Good.
Well, because don't forget when you're being pricked, the cortisols can go up.
Yeah.
So your level, yeah. I mean, it's also not fun to be pricked more than it's.
And I have asked numerous times, and yet my endocrinologist's office insists that it can't be with an IV, so. Thank you.
Yeah, we do them all IV
Yes,
for patients.
thank
experience.
Just
Yeah.
might be a quick question, might not be. If not, then I'll catch you later. If somebody has adrenal cancer,
Uh-huh,
can they also have adrenal insufficiency?
yes. Yes, but they need to be tested.
Thank
you.
No, it was me.
Because I've had, several days.
So very good.
And diarrhea. I couldn't take off.
I really, like that there.
I don't mind.
No, I, yes.
I had
think
really
thanks for
good
setting it
at-
up.
I'm curious about what. Now, confirmation of this.
And I tried this morning and I checked my conservative. Oh, what am I paying for this for?
Yeah,
So
and I didn't know
tomorrow,
I did it. That's
this is what everybody what's their name exactly.
Yeah, it's wrong with that, like, so, yeah.
Somebody had a.
We have house lights, so those aren't.
And it says room.
No, we're not gonna be.
Counseling sessions in the room.
Yeah, those are not.
Without Zoom. Oh,
I know.
well,
Yeah.
we're doing all right now since you've done that. People are coming in. I mean,
Okay, good.
we have plenty of people in. We have like 15 in Sontag with the 17, 16 here on, and then the rest is stadium. So people are going where they can.
Fantastic. So yeah, I posted it up on the Facebook page, so they should be able to get it everywhere.
Awesome.
So, and I'm hoping, well, if they registered, they have to, and they have to. Yeah, well,
Yeah. No. Want to use the mic? You can. Hear you coming through.
Everybody hear me?
You leave for the day?
You can hear me now? It's all good? So I'm Mike Thompson, I'm the dentist. I'm here to learn. A member of the Facebook group. So if you
My
can
wife
add
is
in
the,
the Facebook, like
The acromegaly. I am, quick little.
I mean, you can use this if you.
It's
hard to hear. Can you hear me?
No, there's air on and.
I mean, he was 9 months old, he was bigger than he was parents and 11.
Thank
You wanna use, yeah, you can.
Until he got.
How's this?
Thanks, man.
Okay. So I have a synopsis that I'm gonna pass out. Anyone take a copy if you like. Okay. This basically is the essentials of what I'm going to say. And then after I've said it, we'll do a deeper dive into details that are relevant to you individually and as a group. Hopefully, we can work with each other and learn each other. So why am I here? What do I have to gain? My wife asked me if I'd do this lecture. And nearly 60 years ago, when I asked her to marry me, I learned quickly that there's 2 words to having a long and happy marriage. You got it. So that's why I'm here. I'm a 78-year-old dentist, still practicing, slowing down. I'm not interested, I'm sorry, in any new patients. So I'm not the man. I'm looking for more time for seeing, adventuring, fishing, and down. But I still do a lot of dentistry. I see kids from in mommy's tummies on up to 101-year-old patients. I got a full range of patients. One of my goals as a dentist is to relieve pain and suffering, whether it be from acromegaly, anything else, and restore function and aesthetics. And then I teach prevention of future problems and maintenance of health. That's where I'm coming from. So there are a lot of things in dentistry that happen, whether it's acromegaly or not, that we can work to help. So I'm just going to quick read this because people online don't have this, okay? So acromegaly in the mouth, a synopsis, Michael Thompson. The excess growth hormone produced by pituitary adenoma may result in a variety of mouth problems, enlarged lips and or tongue, poor growth of the lower jaw, tooth, bone, and gum issues, leading to looseness and or increased spaces between teeth, resultant changes in bite, making food mastication difficult, consequently pain in one or both jaw joints, and associated ligaments and muscles, hence the TMJ syndrome as it's called, as it relates to the temporomandibular joint, TMJ for short. In addition, hormone-caused excess growth of tissues in the back of the mouth and throat, plus the tongue, leading to sleep apnea disruption issues of snoring and or sleep apnea in caps. Fortunately, much can be done to mitigate these problems, the most serious being sleep apnea, in my opinion. This malady presents, in my opinion, the most serious risk, that of sudden premature death. Untreated, the patient is 8 times less likely to wake up in the morning. In addition, sleep apnea patients are at increased risk of cancer, heart attacks, strokes, and other things I'll mention shortly. Therefore, a sleep study, preferably under the supervision of one's physician, warrants top priority, in my opinion. If sleep apnea is diagnosed, a continuous positive air pressure, or CPAP, nighttime breathing apparatus can mitigate this problem. A specific dental appliance might be also effective to overcome sleep apnea. Caveat, an intraoral sleep apnea appliance should be fabricated and maintained by a dentist trained and experienced with this service. And its effectiveness confirmed by a physician working closely with the dentist. Know that some movement of the lower jaw front teeth is a normal side effect with this appliance. If no sleep apnea is diagnosed, I recommend a night guard appliance for everyone in caps. Whether or not acromegaly is diagnosed, the current statistics reveal that up to 93% of adults clench or grind their teeth day and or night. And without intervention, this results in serious damage to the teeth and or gums and places one at increased risk of the TMJ syndrome issues, which we mentioned. A custom-fitted guard fabricated by one's dentist represents, in my opinion, the best protection. But an equally effective local drugstore or online full arch guard, such as those available at Walgreens, Rite Aid, or CVS, or other pharmacies or online sources, such as the brand name Dentic, I have no conflict of interest here, may help diagnose, mitigate, and prevent bruxism. The remaining acromegaly-related mouth problems may be successfully minimized, treated by one's dental team members. That's my synopsis. So, let's go through some of the things. First off, I want to talk about is the sleep apnea, because I've heard that not mentioned earlier today. Sleep apnea has a number of sequelae. I'm going to read off this list. Memory loss, cognitive error increase, irritability, mood shifts, daytime sleepiness, high blood pressure, coronary artery disease, stroke, headaches, dry mouth leading to increased decay and gum disease, pulmonary hypertension, reduced libido, depression, sudden cardiac death, gum disease sequelae, also associated with that, cancer, heart attack, and stroke. So a lot of problems are dental related to this. So let's go talk about the bones. When you have acromegaly, the hormone produces bone growth. Lower jaw is one of the more common places, but can happen in the upper jaw. And there's a whole range of symptoms and side effects with those dental things that make it really difficult for a dentist to see, because there's a whole range in levels of hormone and how it affects you, how your body responds. It makes it really difficult. So dentists don't always recognize it. I didn't recognize my wife. I did recognize her sleep apnea. And I referred her to a physician. He did the diagnosis and testing, and bingo, that's how they found her pituitary adenoma. Okay. Now, if I were to diagnose the sleep apnea, because my area of expertise is the mouth. It stops at the back of the tongue. If I were to diagnose and treat the sleep apnea, that's medical malpractice. Okay, that's beyond my area of expertise. And I have a little problem aside. I have a problem with people in politics who are diagnosing women's health issues and really making laws to control that. I'm upset about that. So I won't go further there. But anyway, that's with the bone growth that can move often the lower jaw, because depending on your circumstance, the lower jaw bone grows more than the upper jaw bone, and it can grow as like in the ramus area on down. So the whole set of teeth grow forward and there's no spacing. It's normal. Or the upper jaw can grow and it grows out, and now you've got spaces between your teeth. So normally the way the jaws and the teeth relate is what we call a class 1, 2, or 3. Those are the range that we see no more often. So the class 1 or normal is where the upper teeth overlap the lower teeth, maybe a few millimeters. Class 2 is where the upper teeth are excess overlap over the lower teeth. Class 3 is where the lower teeth are edge to edge or in front of the upper teeth. And that applies to the back teeth as well. Because normally there's an overlap in the upper jaw of the upper teeth outside the lower teeth. And it can be the lower jaw teeth outside the upper teeth. Now, the problem with, you can have a class 3 and have no acromegaly. There are a lot of people class 3, class 2s, and that's related to America being the great melting pot, because we have people from different ethnic regions of the world coming together, different sized jaws, different sized teeth. If you were to go to the outback in Australia, you'd see people with perfectly proportioned jaws, all 32 teeth, no wisdom teeth issues. They're all beautifully aligned because that's what evolution's done for them. But America, we bring people together, it's an orthodontist nirvana, because everybody needs to get their teeth fixed for one reason or another. And then when you throw in a hormone imbalance and cause acromegaly, it makes it difficult for us to diagnose, much less treat. So that gives you an idea about the teeth and jaw spacing, okay? So any questions on that? Because this is open. Okay, cool. So let's talk about the gums. Okay, so if you have issues with your gums, that can be related to acromegaly or not. I just went to a lecture last weekend getting the latest on dental health periodontology from a periodontologist in Santa Barbara. The latest deal there is 1 out of 2 Americans have gum disease, 50%. Okay, and that is related to, could be acromegaly, could be related to what's now called biofilm control, or we used to call plaque control. Okay, so, and that was Saturday class. And then Monday I learned that if you have a chronic inflammation anywhere in your body, you are at increased risk for cancer because of that, right? Well, gum disease is now considered a chronic inflammation. So gum disease makes you at increased risk of cancer. So there's a lot of things going on here at the same time. So, but what do I deal with and what do patients deal with? So we deal with what you got. So if you have, for example, teeth that are out of line, jaws that are out of line, and it's making it difficult for you to chew, and you're uncomfortable because your joints are becoming inflamed, your muscles and ligaments are becoming inflamed because when you put your teeth together, they don't match, okay? So then we go back to basics. The basics are the only time that your teeth should be touching or coming together is when you're chewing or swallowing. You set your teeth together to swallow. The rest of the time, there should be a space between your teeth. You should not be bringing your teeth together, okay? So if you bring your teeth together and they don't match, it's okay. Don't bring them together. fix that problem, okay? Now, when you're at night, now is the problem. You can't control your unconscious. Okay. Well, and your teeth don't come together right, so that's going to be uncomfortable. It's going to set up problems. Oh, we can fix that. You wear an appliance, a night guard. And what that does, how many people wearing a night guard? Okay, good. So about 30 here. So people, when you're wearing a night guard, it's most often on the top jaw. And then the top teeth have the appliance covering them. The lower teeth now, they bite into the appliance, which is either a soft plastic or hard plastic. And it's a solid surface, flat surface. So now, all of a sudden, your bite's right. Your occlusion's been fixed because now the teeth are meshing nicely. Okay, so that nighttime problem has been eliminated. And you're not going to bring your teeth together during the day. That should help a lot. Now, if you're in a patient who's having a lot of stress, like COVID, we had a pandemic of dental problems because people were clenching their teeth under all the stress, busting fillings, busting teeth, knocking out crowns and ridges and everything else because that does damage. So wear a guard. Everybody needs to wear a guard, in my opinion. And so if you're having a crisis and you have problems with a TMJ, you wear a guard day and night. Now it's called splint therapy because we're not going to wait for you to remember to keep your teeth apart. We're going to remind you with an appliance. Well, we should talk about what does a night guard do? 3 things. Number 1, it diagnoses the problem for you. So a lot of people come to me and I look in their mouths and I see these mirror smooth flat surfaces on their teeth, wear marks. And I say, it looks to me like you're grinding your teeth. They say, no, I never. Okay, fine. Wear a guard for a few nights. Then you look at it and you'll see the track marks. But there are people that don't grind their teeth. My wife's one of them. She never clenches or grinds her teeth. What every mammal does that I know of is the muscles twitch. The muscles twitch when you're sleeping. And what Carol did, bless her heart, is these muscles would twitch. Click, 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 click. And through evolution, we're engineered to last about 50 years. Our teeth are. Now, if you're healthy, you're expected to live to be 100. Okay? And if you want to take your teeth with you, you need to be kinder and gentler to them because this click, click, clicking causes stress cracks in your teeth that eventually end up with your teeth literally falling apart. 70 or 80-year-olds, I've seen that. Yeah. So, but it's all good news because we can fix it. Good news. We see a lot of this, the wear, whatnot, from grinding with acromegaly or any other source or saw cause. Front teeth, because they're the thinnest, often go first. You will lose the biting edge of your front teeth. They start chipping and falling apart a bit. Good news is it's easily fixed. Your dentist can fix it with a little composite bonding and painless, no drilling, really good. Nice technique. Okay, so that's something with the teeth. A little bit about the gums, a little bit more about the gums, because we talked about that a little bit. Okay, so gum disease, like I say, 1 out of every 2 people have gum disease. So plaque control or biofilm management is critical there. And the deal is, I've served in the peer review committee in California for 30 years. And I'm a member of the American Dental Association. So I'm pretty sure the standard, I've been calibrated and measured. So I know what the standard of care in California is, what dentists are supposed to be looking for and treating and doing. And I think it's pretty much standard across the country now because I did a hospital residency in Florida for a year too. Every dentist or hygienist, when you're cleaning your teeth every 6 months, ideally, or more frequently, depending, should be probing for pockets. Does everybody know what pockets are here? Yeah, great. Okay. So if they're probing for pockets, then they're going to catch a gum problem early. That's the key. As in anything else, if you catch this thing early, make the diagnosis early, then you can intervene and treat it. The dental problems with gums most often are because you have a pathological organism in your mouth that's gotten in the crevice between your gum and your teeth. And if it's not cleaned out on a routine basis, stirred up oxygen enters to that area, then it's going to cause inflammation to the tissues, which are going to respond by becoming swollen, inflamed, and bleeding, and then detaching from your teeth. Okay. Well, by the way, heart attacks and strokes, we should talk about that with gum disease. Does everyone know about gum disease, heart attacks, and strokes? Okay, cool. So you know that if blood can get out, bugs can get in, and they get in your bloodstream, circulate, and they can cause agglutination of your platelets in your heart or your brain, hence stroke or heart attack. Okay. Any other questions on that so far? Okay, so a little about sleep apnea, because I haven't heard that more this morning. So what is sleep apnea? Sleep apnea is when you're sleeping and as you go into deeper sleep, the tissues of your tongue and or throat relax. And related to acromegaly has been a growth of your tongue and or tissues in the back of your throat, so that now the space for you to breathe has been reduced. And then the muscles relaxing in that area result in collapsing of that space. And so what's happening is your diaphragm's working and nothing's happening. There's no air passage. And this can happen for an extended period of time. And as it's happening for an extended period of time while you're sleeping, your body organs, tissues are being deprived, starved of oxygen until the point where your carbon dioxide level goes up. And that stimulates you actually start to wake up a bit. You may be still unconscious, but now you're breathing again. And depending upon the severity of sleep apnea, that can be you're breathing again for a few seconds, and now you're no longer breathing. You're no longer getting oxygen. So sleep apnea is very, very serious. So for that reason, I recommend everybody get a sleep study if you haven't already done so, and be treated for it, because it's very deadly. Any questions on that? Okay, cool. Well, TMJ, that's where it touched on TMJ, because talk about joint laxity for a little bit. Okay, so TMJ issues, if you have, like, if the joint become too loose, you can open wider and wider. Now, the way the jaw, bones and the skull work is your lower jaw is, your teeth are going to be down here by my elbow. Sorry, folks online, you can't hear this, see this. But you think about a ball and socket, only it's different from a ball and socket. It's more like, you know, a shark opens its mouth, right? So as you open your mouth, you close the mouth, so as your lower jaw drops, this now ball and socket can slide. And now the lower jaw slides forward, allowing you to open even wider. So a shark can go like this, kind of like the alien, you see them. The thing comes out and grabs you. Okay, not quite as bad, but the lower jaw can drop. So what happens is the lower jawbone can slide past the little prominence here in the skull. And once it goes beyond that, it go whoop. Now it's stuck. You can be stuck fully open. And that's very painful, because now in order to get it closed, you have to push down and back. Okay. Do you know how to do that?
I've spent about 8 months last year working with a TMJ disorder specializing PT. Learned some things.
For the rest of you, what you have to do in case it happens, or if you see it happen to somebody else, because unless you know how to do it, it ends up being to the ER and you spend an hour in agony while you're waiting for them to treat it. But it's simple to treat. You grab the lower jaw with the teeth, pull down and back. And that resets. If you're doing it yourself, it's easy. If you're doing it somebody else's, you don't want to do this without gloves and stuff. Because you have to put your hands in their mouth to do it. Okay. It's the reverse of what you do for CPR. CPR, you pull the jaw down and forward. Okay. This is down and back. Okay. Any questions on that? Okay, good. Now, to avoid getting into that position, okay, so if you've got laxity in your jaw joints, you don't open wide like that, okay? If you got some nice big apple you want to bite in, no, I'm not going to bite that apple. I'm going to close a little bit, cut it in quarters, something like that. And if you're having issues with TMJ, the muscles and ligaments are getting sore and tight, rather than opening it wide, you cut up your food first, chew little bites and chew it slowly and carefully. With acromegaly, if you've got your lower jaw out of position, right, and your teeth aren't functioning really well, you can't bite a sandwich. Forget that. You can't bite lettuce very well, so you have to cut it up, okay? A knife and fork works great, okay? Smaller pieces, okay? Spend more time chewing slowly and carefully. It's better for your digestion, okay? Any questions on that? Okay, cool. See what else I've not covered. Okay, we're looking pretty good. Okay, so a couple things more. Any other questions so far before we go forward? So I think I've touched most of the things. Tell me if something happened and you want to chime in here and tell me some of what your experiences are. That's great. Bonus. Alzheimer's. So we talked about cognitive impairment, stuff like that. If you're having trouble, you've had trouble with sleep apnea or anything else, if you have issues with your brain functioning really well, that can lead to memory issues, cognitive impairment, dementia, Alzheimer's. Okay, you're at greater risk for that if you have that history. In fact, we all, if we live long enough, will get Alzheimer's. That's how it is. Our brain loses synaptic connections over time, so we end up losing our ability for the neurons to connect with each other. Hence, we cannot recall memories, we cannot function properly. We die of Alzheimer's. That's the thing. So the key is really neurogenesis. Neurogenesis, everybody know what that is? Neurogenesis is when your brain recruits stem cells from in your brain tissues and or your blood vessels, and you grow new neurons. And you develop new connections between those neurons. Okay? Excuse me. So how do you get neurogenesis? What can you do to forestall Alzheimer's? Anyone know? There's something that you can do which reduces the risk of Alzheimer's by 76%. Nothing else comes close. So about 30 years ago, a number of universities, Boston University, Albert Einstein, knew that Alzheimer's was going to be increasing in this country. Well, they saw it already, okay, because of the increasing age of the population. So they embarked on a study. They took a large group of people and following what they're going to do, what they've been doing for exercises and mental stimulation, because we all know that if you're stimulating your brain, that there's benefits to that. And if you're exercising, you're getting good cardio workout, you're getting good perfusion in your brain, so actually there's benefits for that. So what they found over 30 years, they followed this group of people like they're in their 50s until they're in their 70s or 80s. And now they had a pretty good pattern of who had Alzheimer's or not. So what did they find? They found that if you do like a Sudoku puzzle, there was a benefit because it's stimulating for a strong, about 15% reduction in risk. If you did exercise on an exercise bicycle, you're just sitting there and pedaling away, your cardiovascular system is fine, but no, sorry, didn't do too much benefit to your brain. But if you do ballroom dancing, there's a 76% reduction in risk they found. Why is that? Well, the theory is that in ballroom dancing, you are having to learn a very complex skill set with your feet. In other words, not stepping on my wife's feet as I'm dancing, okay? And you are having to do this with music, which is entering, you're doing it by yourself, number one. You're doing it with a partner, that's ballroom dancing, number two. Each time you add to that, it's basically multiplying the level of complexity and stimulation and challenging for your brain to do. And you're doing this with other dancers, number three, so you're not bumping into them. So it adds incredible levels of complexity. That's the theory behind it. The bottom line is if you're doing ballroom dancing, you're getting good cardio workout, and you're dancing with a spouse or a partner. So that's really good for relationships. And then it's good for your brain because it keeps you sharp intellectually. So that's a little bonus for today. Okay. So unless there are any other questions, you can check your email or
Would you suggest for a person, what would you suggest for a person who has a, like a class 3 bite, chews all the food in the front because the teeth in the back don't go together, and plays clarinet for like 10 hours a week?
okay, you hear that? What do you do if someone's got a class 3 bite, the lower jaw's in front of the top jaw? They chew all the. Okay, that's edge to edge. That'll be class 3. Okay, so if you can meet them, you did work. Okay, and you play the clarinet 10 hours a week. Keep up the good work.
It's hard on the front teeth. I mean,
Yes, it's going to be
chewing the food is hard on the front teeth.
okay.
When you say, there's been dentists that have said, oh, well, you grind your teeth. Well, no, I really truly don't. I've done the study and
Okay.
everything. It's chewing my food.
Okay, so I see that a lot. Okay, I'm 50 years. I see in a lot of people who have what we call an edge-to-edge bite. It's one of the worst bites that you can have because when you're chewing your food, you chew through the food and it bang, 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 bang. Your front teeth are meant to act like a scissors where the blades pass each other. They don't do like this. Okay, so if you're doing this bang, 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 the teeth are made of 3 layers. The outer layer of enamel is crystalline. It's metal. Calcium is metal, magnesium phosphate. The middle layer is dentin, that's like bone. And then the core, center of the tooth, is the nerve, that's basically liquid. All 3 of those layers are held together by microscopic apposition. There's no bond per se between those layers. It's just how they're deposited by the cells as this tooth was developing. So when you start biting like this, and if those teeth edges are touching when you're biting through your food, you are physically stressing those teeth. And as I was mentioning earlier, over time, you're going to cause the enamel outside to chip and crack and wear. Okay, so it's best for you when you're chewing your food not to bring your teeth together, but to use your knife and fork accordingly and come close together. Okay, so yeah, that's a. I know that's hard to do. It's easy for me to say than for you to do. Okay, but bottom line is, okay, good news with you and with a lot of other people too, is that when you wear those teeth down, and you will see the difference because if you look at the, you can see it easier in the bottom front teeth because the biting surfaces are visible. The top front teeth, the biting edge is on the tongue side of the tooth, so you cannot see it so well. Okay, but in the bottom front teeth, you can see that, and when you see that, you can see there's a difference in color. You'll see the outer layer is whiter, then there'll be a little dark line in the middle of the biting edge. That's the dentin that's been exposed because you've worn through the enamel. Okay, once you expose the dentin on that tooth, any teeth, it's softer, more susceptible to wear. It'll wear faster than otherwise. So now you'll start having the enamel is unsupported by that dentin that's worn down. So the tooth will start chipping and cracking, and that happens a lot, especially on the front teeth, the top front teeth, because there are actually 3 tooth buds that fuse together. And what's really a crisis is that the fusion line, depending upon how your own individual teeth develop, that fusion between those tooth buds may be more or less perfect. And so you can be chewing your salad and all of a sudden your front tooth falls apart. Okay. So the good news about all this is we can fix it. Okay. So if you wear down the bottom front teeth, you start getting the dentin exposed, go to your dentist and have them put in a new layer of enamel. We can just simply bond some new composite on there. Ideally, it's done with a little air abrasion, so you clean up the soft stuff and then build it back up to you. So it's all enamel now, it's exposed, or in this case, composite, which is equivalent to enamel. So now you got like new biting edge, okay? And top front teeth, let's say you split your teeth. Or let's say, another case example would be if you do a face plant, fall down and bust a tooth, or know somebody, grandchild who does that, do you know what to do if you got a big hunk of your tooth fall off in the front? So if the whole tooth comes out, that is the best thing to do. Like you said, put it back in. So if you have your whole tooth knocked out, clean it up gently. Do not scrub it because it's got cells on the outside. It's going to be ugly and red, so it may be too much for you to handle. If you can handle it, put it back in the socket. That's the best place for it to be. If you can't, put it back in the socket. Next place is in the sulcus between your lip and your teeth. If you can't do that, you're really worried about, or it's a small child, you're worried about what you're going to do with that. You can put it in saline. Isotonic saline is best. Who has isotonic saline in there?
Yeah.
Right? Everybody does. Isotonic saline, 1 cup, 8 ounces of water and a teaspoon of salt. Mix those 2 together, it's isotonic saline. That's the best place for it, okay? Refrigerate it, could you do that? That keeps the cells alive. Milk also works. Bring that piece or tooth then to the dentist. We can literally bond teeth back together. I've seen videos where a lecturer was talking about a little 8-year-old came in and he had a face plant, broke off his front teeth, like 1/3 of the front tooth, but the parents got it. He put it back on, bonded it back on. Looks just like normal. Unfortunately, the child did not get safety fall or tumbling lessons. Another couple of years, he was back, face plant, busted the same tooth again. Different place this time. Yeah, the tooth broke, different from where the dentist had bonded it back together. So we can do some pretty good bonding now. That applies to front teeth, not so much the back teeth. So, yeah. Question.
Can anything be done if you have severe bone loss in your jawline and your teeth? That I've been told by a couple dentists that I've got severe bone loss and that I'm losing some teeth because they're basically, the bone's disappearing. And I said, can I get an implant? And he said, no, because you need bone in order to do the implant.
Right. The question is, if you have severe bone loss in your jaws, what can you do about that? You're losing teeth because of severe bone loss. That's what the dentist said. What's the condition of your gum tissues?
My gums are fine.
No pockets. Okay. So what I'm hearing is that despite the fact that your gum tissues are healthy, the teeth are falling out because of bone loss.
They haven't fallen out. They're both of them have a crown and a root canal, and you can see everything. They're barely hanging on. And the dentist recommends I get them pulled before they fall out. But is there anything to reverse the bone loss or help any future bone loss or?
So, what I know about bone and the jaw bones is that bone responds to stimulation. Bone responds to healthy gum tissues over it. So, if you are brushing the gum tissues too much, so you're causing gum recession from that sort of a trauma, and or if you're unable to keep the gum tissues healthy because of plaque accumulation, then the gum tissue can recede. But so long as the gum tissue around the teeth are healthy, in 50 years, I have not seen teeth fall out because the bone disappeared around those teeth. Because so long as the teeth are there, the teeth actually are going to be stimulating the bone. The teeth are held in the jaw bones by ligaments. It's actually a joint. And when you chew and use your teeth, that's putting tension and stress on the bone. That stimulates the bone to be strong and healthy in those areas. What happens when you lose your teeth, disuse atrophy, it wastes away. That's when the bone and gum shrinks and you end up with dentures which don't fit because the tissue shrinks underneath them. So my opinion is that you want to hang on to your teeth as long as possible. Extraction is the last resort. So I've had patients that had gum issues with their teeth, and we still try to hang on to those teeth as long as possible, because as long as those teeth are there, we can get the gum as healthy as possible. That's going to help the bone underneath. Does that answer your question?
Yeah, I even when, because my jaw is so protrude so far out on the bottom, and I went to go check and getting braces to try and fix that, and they're like, we're afraid if we do braces, it's gonna pull your teeth out because you have so much bone loss.
Yes.
That happened to me.
Yeah. So that's a good point. So can you do braces to realign your teeth? And when your jaws? And when I started practice back in '74, actually orthognathic surgery was a common thing that was done, whether it be for acromegaly or for differences in jaw growth, because there's some people that have a bigger jaw, top or bottom, than the others. And so the solution to that problem was for a surgeon to go in and literally cut a section of the skull, in the case of the upper, or cut a section of the lower jawbone, and then either advance or retract that, and then reposition it and hold it together with screws. And then the orthodontist would pull bands on there and hold the whole thing in place for 6 weeks. And that would result in a beautiful bite, nice aesthetics. Great. But long term, what I see is because of the trauma of that, screws in the jawbone areas, often they result in devitalization of the teeth in the area. So we end up with problems with that, as well as numbness issues with that, paresthesias. So that's not done very much anymore. And that's doing this in young children when the jawbone will heal very quickly. If you're talking about doing braces in adults, other than Invisalign, which you can take out and clean your teeth really well, now you're putting all this stuff in your mouth with braces. And it's been another problem with adults is if you do standard metal braces in the mouth as an adult, and I'm talking about someone who's 30 or older, the body doesn't respond as well. Your resistance is not as great as kids. With kids, you can put braces in their mouths and there's all kinds of stuff going on. Most of the time, the body's able to deal with it, keep the plaque at bay because your own antibodies are high, et cetera. But as an adult, I've seen it happen time again, where they take the braces off and the gum is so bad that the teeth are all lost or the roots are gone. So I don't recommend that as a general thing. So I just deal with what you got. I would recommend splint therapy, keep your teeth as clean as possible, knowing full well that when you are talking about cleaning your teeth, that's every surface of every tooth every day. Starting out once a day, at least when you're 6 and you get your permanent teeth in, permanent molars come in and permanent teeth. And when you turn 25, 30, it becomes twice a day. that's flossing and brushing. And when you're 40 or 50, 3 times a day. And knowing full well, this is prevention, that 80% of the problems that we see with gum tissues and teeth start between your teeth where the toothbrush won't reach. So that means flossing or something the equivalent of flossing. Fortunately, for people who have difficulty with a string, you can use now the waterpick flosser. I have no attachment with that. Okay, but the new waterpick flosser works as well as the string floss if you use it properly. So that's cool. You can also use a toothpick, but if you're going to use a toothpick, you have to use a toothpick holder because the toothpick, the whole length of the toothpick will only work from the outside half, top and bottom teeth. You can't get at the inside half in between. So you have to use a toothpick holder for that. It's called a perioid. Maybe you have to find that online. Your dentist might carry it. But that should be sequenced ideally. You clean between your teeth first, brush second, mouthwash third. And mouthwash, Listerine or the equivalent, anything that's got the American Dental Association seal approval on it, ADA seal, shows they got the data manufacturers, the data shows that it's going to work. Does a good job. Okay, you do that, you're going to eliminate 90% of the bugs in your mouth. And that's key because all you need is 10% normal flora in your mouth for you to be successful. Now, I've seen patients who struggled with their gum tissue health for a long period of time because the microbiome in their mouth was not good because they're unable to do the control in between your teeth. You need to stir up the plaque that's in between your teeth, oxygenated, because oxygen is the #1 killer for bad bugs. The bugs that are pathogens are anaerobes. They cannot tolerate oxygen. So if you're simply stirring them up, you're including entering oxygen into their little environment, then they die and they're replaced by good bugs. And what I've seen happen is people who've been struggling with gum disease, and we finally get them to the point where their gums are good, their pockets are all normal. Now they're in great shape because now they've got the bugs in their gut working for them. I don't know if you've ever seen the microbiome in your gut movie that the Gates Foundation published. Know that one? I think I wrote it down here. Microbiome in your gut is one thing that I reference to, but it's a cartoon. When you look at that, it may have another title on it. Now the latest cartoon that they have is something like the bacteria in your mouth that control your health, something like that. There's several videos out now, and anyone know about poop transports? Poop transplants? Okay, yeah. So that's part of that program. So not that I'm advocating that yet, but I think that's the point. Is you want to get bugs in your mouth that are the good bugs. Once you get the bugs in your mouth that are good bugs, they're going to work for you because they're going to inhibit the growth of the bad bugs. That's what I see in my practice. Once someone gets in a healthy situation, they're in good shape. But you got to do that important stuff. I had a patient that for many years, David, couldn't get him to floss regularly, He went to Northern California, quit soon. He went to Northern California to help out his son with the house. He had fixer-upper. And he came back home to Santa Barbara, where my wife practiced, and he forgot his toothbrush at his son's house. Now, this guy is an engineer. He could afford to buy a new toothbrush. He says to himself, well, and he's telling me this story. I was checking him before the hygienist Lisa cleaned his teeth. He's telling me the story. He said, I knew you were going to give me a toothbrush, and it was only 3 months before I was going to have my cleaning. So I'm going to do what you've been telling me to do. I'm going to floss my teeth, but not brush them for 3 months. And Lisa is going, her eyes doing a big eye. She's thinking, what am I going to see when I get in there, right? Guess what? He got his best dental checkup ever. Yeah, because there's a lot of self-cleaning that goes on with your cheeks and your lips and your tongue that you don't know about, but they can't get in between your teeth. So if you do that job, it's going to be good. Oh, by the way, I'm seeing patients who, for one reason or another, were unable to or unwilling to get in during and after the pandemic, right? So now it's like 5, 6 years. But Dr. Thompson, I was doing my homework. I did my flossing every day. Guess what? They're okay. Now they got more calculus build up than before. The hygienist has to work a little more, but they're in good shape. Yeah. So what you do for your homework is critical. Okay. Unless any other questions? All right. Thank you for your attendance. It's been great.
Yes, it worked. It has.
Yeah, because I grabbed my hand. It's like a U shape. They can take a hold of it. And it's flat.
Those, pages that were on the chairs. Thank you very much.